Voilà, voilà, bonjour à tous.
Okay, so here we are.
Merci Isabella pour avoir
Thank you, Isabella, for setting such a high standard with your moderation. When I die, I'll have time to organize myself because I have many things to do.
Voilà, donc après avoir prédit,
So after predicting, we have to prevent, of course. To prevent to what extent? This is a question that Guy Valencien asks us this year. Thank you for taking the risk of allowing me to moderate this roundtable. Last year, I was talking about bioterrorism, so this is fairly simple compared to bioterrorism. And I'm very lucky that I'm surrounded by very prestigious people and all important actors in our healthcare system. We have a great roundtable. I hope we don't run over time. Otherwise, Guy, you can cancel the next roundtable. So the theme of this roundtable, how far do we go in prevention? Numerous reports have shown that France is at the bottom of the class in Europe concerning prevention. Should we believe these reports? This isn't really the subject. Before we decide how far we have to go in prevention, we should start with the beginning. Prevention isn't easy, especially in certain pathologies. When diabetics, for example, their problem is a figure on a biological report. There's no change. There's no change of mood. Same thing for alcoholism and tobacco weaning, and for cardiology. It's difficult to prevent as well. As we're in a minority, David, I'll ask the question to you first. You're a general director at Malakoff Humanis. We have a specific thing in France, which you have a hybrid system, a public-private system. Is this a benefit for prevention? I think it's a good thing for the... You have 1 minute. Yes, this is a good thing for us because less than 300 euros per person. We're one of the best placed countries in this area, but in many other subjects we're not well placed in especially prevention. I'm not a physician or a lawyer, I'm an engineer. I've been in the tech field since so small, and we've been working in IA for about 12 years in AI. I still haven't really understood this complex hostility to tech in France, especially in healthcare and especially regarding data. That's my first remark. Behind this, we have the idea of the protection of the individual we've mentioned earlier, which is necessary, but which shouldn't prevent us from using the potential of data or even replacing humans and physicians. I think in that discussion, we are going in the wrong direction. And until we reassure ourselves in this area, we won't be able to use the full potential of technology. We won't be able to do prevention and personalized prevention and be able to scale up unless we use tech and we use data. Personalization is extremely important. And when we say data, I'm talking about healthcare data, whether it's medical or biological, but also environmental data, socioeconomic, vocational data. And we know very well that today we have a lack of knowledge of the determinants, and that's why we have this fantasy of prediction, which I don't believe in at all, for various reasons. If we have time, I can explain to you why. But first of all, before we predict the future, let's analyze the past in an intelligent way. And in France, we are lucky because we have databases that are unique in the world. I'm thinking of the STIRAM, the medical database for insurance, the LINCA database as well, consolidated with the databases of other areas in occupational health, for example. We have a data capacity which is unequaled in the world. You've already run over your time, by the way. Of course, I was saying earlier, it's difficult to raise people's awareness in this area. Up to now, the prevention campaigns don't really work very well. Yes, they don't work very well because they're not personalized. You can have primary prevention using communication campaigns. It's important. It contributes to education. We have to carry on with school medicine and workplace medicine as well. This isn't enough. If we want to scale up personalized prevention, we're talking about visits at 45 and 65 years. That covers about about 2 million people with the screening systems. This represents about 2 billion euros altogether. It's not just a visit with a GP, regardless of the competence of that GP. It isn't going to work, and prevention isn't 25, 45, 6 years old. What happens between those ages? We have time to die, as Nicolas Bouzeau said. Personalized prevention has to be based every day on data analysis. We have the capacity to develop detection algorithms, to define a risk profile, and to define the best areas for carrying out prevention. This is what we've done with Malakoff. We work on a cardiac assessment system, and we've been able to save lives thanks to that. Except here we're in a rather unusual context with a crisis, with a lot of vulnerability and poverty coming up. Isn't it rather difficult Dominique Stoppa-LYONNET to promote the importance of prevention and not see it as a secondary. Well, prevention, let me take the example of cancer, which I think is a real paradigm for the prevention because it's primary prevention. You mentioned prevention concerning alcohol and tobacco. It's also secondary prevention. It's screening. Today in our country, we have screening that is organized for cancer of the breast and the colon. It doesn't work very well for the cancer of the colon. It doesn't work very well. It's only 30% of people who agree to do it, and with a lot of disparity according to the areas of France. Another interesting thing is that the best pupil is Vilaine, with 45% of participation in this screening, and then the worst pupil is Guyana, and also Paris, because the health conditions in Paris and Guyana are very different, so that raises questions. So I would say, what are the reasons people don't participate in screening? And they are very complex, and we have to work on that. And for the cancer of the colon, the screening of the cancer of the colon is secondary prevention, detecting cancer as early as possible, and also primary prevention, because a polyp that is bleeding is easy to detect and makes it possible to prevent a cancer. We also, if you're talking about cancer, of course, this is my main subject. It's the idea of personalized predictive medicine. You say you don't believe in it, but I mean the 4P medicine. Yes, you can have a link there with the previous roundtable. The 4P medicine is, first of all, you could say maybe we could go about forecasting rather than prediction. We're talking about prevention. We're working on personalization and participatory. So there's 4Ps. Those 4 elements are very important, and I would say that the beginning of this morning is very focused on participation. We've talked about democracy in healthcare. It shouldn't be just an empty word. We have to bring together all of the stakeholders, the practitioners, the patients, not just the patients, because we're talking about prevention. So we're considering the whole of society, not just the patients. We are all at risk of a particular disease. So to come back to the predispositions to cancer we've seen over the last few years, many wonderful approaches and great progress being made, but there is still a lot of work to do. We have fantastic capacity for sequencing of genes, for all of the genomes. But let's come back to what was said in the previous roundtable. We talked a lot about technology. Technology is essential, and it's a driver, but the difficulty we have, the challenge, is for genomics, is to transform sequencing data into medical information. There is a step that we have to take there. That's the importance of accumulating data, clinical, genetic data, etc. That's why it's so important. Audrey DERVELOY, you're a physician. You have become recently president of Sanofi France. When we think of the pharmaceutical industry, we're thinking of corrective rather than preventive, of curing rather than preventing. What is the role of pharma in that area? Yes, I think we are seen as being curative, whereas we should be seen as curative, obviously, but also as playing a preventive role. We offer drug-based solutions solutions and also overall solutions around the patient journey, including preventive elements. So this is the big problem. Why aren't we heard more? Why aren't we invited to the co-construction systems? As you said, we need everybody. We've seen that industrial companies and the latest developments show that there's a real problem with the positioning of the pharmaceutical industry. We are seen as a cost, a burden for the society, rather than an investment. To come back to drugs, if we look at vaccines, we have vaccines today which are making it possible to reduce congestion in hospitals. What else? What more can we do to improve access to these vaccines and make sure that healthcare practitioners and patients too will be able to benefit from this prevention? I'm sure you've seen for bronchiolitis, 35,000 hospitalizations for children aged less than 1. It's 116 million euros every year. What do we do about that? We should be invited around the table for us to participate and for our medicine to be considered as part of prevention. When you imagine a drug, it's often, from the time it's first imagined and then actually released, 10 or 12 years can go by. So you have to think in the medium and long term. Yes, these are massive investments. In the long term, we have to anticipate. It's not visible, it's not really recognized. And I'd like to speak for a lot of people in this room. I'd like our investment to be recognized. We have investments in France. If I look at the RN NRA messenger platform in Lyon, we're investing 900 million by up to 2026. This should be recognized. Prevention is important, as we saw in the previous roundtable. It's not just something where you see the effects after 2 months. For us, as in industry, we are investing massively. I would like that to be recognized. Thank you. We've understood that you are the representative of the pharmaceutical industry. Luckily, you come from Ireland. We have Anne-Marie Baird, who is with us. Hello, Anne-Marie.
Voilà, qui nous parle de Dublin en Irlande.
She's with us from Dublin in Ireland. I spoke to her an hour ago, yesterday, for about an hour. She has a lovely Irish accent.
Pour le parigo, c'est un petit peu plus compliqué.
For me as a Parisian, it was a little bit tricky, but I managed. It was fine in the end. So you're president of Lung Cancer Europe.
Yes, that's correct.
Okay,
so
donc
Lung Cancer Europe is a non-profit umbrella organization.
C'est une organisation qui est européenne.
It's a European organization?
Yes, European.
Okay. Donc vous avez une vision peut-être un peu plus globale.
So you have a more global vision of prevention in Europe. Can you see obvious differences between the different countries within Europe?
So there can be differences between different countries in Europe, just how the healthcare system is set up, how the education and awareness is around different lifestyle factors and the impact they have on risk. But I think the other speakers, and this is what happens when you go last in this type of situation, is I think the other speakers have covered many of the topics where we see differences, whether that's personalised campaigns, because I think personalised is definitely a very important thing, as well as the big data that's needed. I agree with all of the things David had said. And, you know, with Dominique, with the screening, some countries are doing better than others in terms of not only having screening programs, but getting participation in screening programs. So all of these things are very different depending on which European country you look at, and even within the regions of European countries. And I think to Audrey, in terms of the pharmaceutical companies, absolutely, there's a curative role there. But people need to be able to access the drugs in order for there to be a curative role. And that would go for medicines and prevention as well, to allow access to those drugs as well. But I think from my perspective, talking about prevention, I think prevention in and of itself is a very difficult word because it lulls people into a false sense of security if they don't obey the different rules or guidelines that are given to reduce their risk. I think we need to start looking at a term risk reduction because it is about being able to be educated and aware of the risks of developing certain conditions, including cancer, and how you work best in reducing those risks. Because I think prevention the term, everyone feels, oh, well, if I do everything I'm told, I'm never going to develop any condition, any disease. And then it tends to make them not aware if they do find something wrong, going and engaging with healthcare systems, if that makes sense.
Alors, on dit qu'il y a des maladies qui sont plutôt...
There are diseases that can be preventable and others that are not so preventable. For you, it's as a specialist in lung cancer, maybe that's the case. David, you're more specialized in breast cancer. Do you think prevention is not the same when a cancer can be avoided? For example, caused by smoking, for example? You can prevent most of these cancers by not smoking. Is this prevention is different for all disease? Is that it is avoidable or not avoidable? Is the approach different?
Well, I think depending on who you ask, they're all going to have very different opinions on this. I think for me, talking from a lung cancer community, it is very important to understand, of course, having a history of smoking is going to increase your risk of the disease, but not everyone with a smoking history is going to get lung cancer. And we need to understand that tobacco use is addictive, and it's sometimes can be used as a crutch for people to deal with life and to get on with things. So you're dealing with an addiction, and we all know addictions are very hard things to give up. I think what has to happen is more supports are given to help people either not start to smoke to start with, to stop smoking, or to reduce the number of cigarettes they might smoke. But it's a very complex area as to why people do certain things and make certain lifestyle choices. It's definitely not an easy thing. And in terms of lung cancer, I think talking about preventing lung cancer again in and of itself is a funny statement to make, because air pollution has an impact on lung cancer, exposure to radon has an impact on risk of lung cancer, and the more we just only talk about smoking and lung cancer, the more disservice you're giving to the 10 to 15 up to 20% of people that get lung cancer that have no history of smoking at all. So I think we have to be very careful of the language that's used around risk factors in certain cancer types, so that we're fair to everybody.
Dominique, c'est vrai que la sensibilisation...
It's true that awareness raising difference depending on the disease. Breast cancer tends to be more hereditary. No, that's not true. It's rarely the case. I'm a cardiologist. That's fine. I don't mind. But some cancers are more hereditary than others. It's easier to raise awareness in some cancers. For cancer of the prostate, for example. Can you carry out prevention more easily in that area? When we talk about prostate cancer with Guy Valencian, it's a big subject. It's not certain that screening of prostate cancer is really beneficial or not. We could have a roundtable on that specific subject. Concerning lung cancer, it's absolutely right what Anne-Marie has said. She's a great specialist. What she said was, there's not just tobacco, but nevertheless, tobacco is a major factor, risk factor for lung cancer. And so we have to make sure that people do not smoke as far as possible. It's a source of despair. The prevention campaigns are not very effective in that area. Concerning breast cancer, there are risk factors we are identifying, but there are some risk factors are genetic with very high risk. These BRCA tests. This is Angelina Jolie was a victim of this type of cancer. We have to be able to predict the risk and have to have a very high level of monitoring starting at 30 years old, and also the prophylactic mammary surgery as well. I hear Axel Kahn saying it's the lowest level of medicine to carry out mammary prophylactic surgery. He wasn't wrong, but today, in certain family situations that are very serious, or when there's any of a serious alteration in people's physical state, we have to talk about it, because there are ways of detecting these things very early on. So these things are being managed for women with a high risk of breast cancer, which represent less than 5% of the total number of women who get breast cancer. We talk a lot about GIBLAS. We talk a lot about primary prevention and how we can share out the tasks between the different actors. One actor works on a particular type of prevention. We talk asked about secondary and primary prevention. Yes, it's not a very clear distinction. There's also tertiary prevention. The important thing is to give yourself the tools to understand what are the important behaviors to adopt to live as long and as happily as possible in the best quality of life possible. The other important thing is to identify risk factors to detect the disease which is hiding. Tertiary prevention, it means that once the disease is there, the treatment is effective and you don't have a relapse. And this is all part of the same subject. In other words, extending life and in good health. And we've been stagnating at 65 years or less. So insurances companies are more in charge of secondary prevention? Yes, that's right. We have a division of roles between don't touch primary prevention. What you're doing in secondary prevention might be good, but here we tend to reason in terms of financing. This is how subjects are dealt with at the moment. People think about financing of the system rather than getting the stakeholders around the table who could add value, not just in terms of co-financing, as I was saying earlier, with our services. For me, secondary prevention, we talk about screening. This is a question of terminology. We talk about a health report, having a regular health blood test and having analysis, and also using professions who are used today, the dispensaries, the remote teleconsultations, nurseries, whatever the level of qualification may be. So there's a prevention journey that is led by this first line before you go into real treatment with a GP and specialists. For me, it's not just a question of financing. There's also a question of having less of a complex about tech, but also thinking about organization and the role that the complementary assurance companies can play, because we have a lot of companies, a lot of French people who are affected by these diseases, and it's an opportunity to promote these systems and to help French people to use the right system. Audrey, you were saying that prevention is everybody's business. You've been able to work and develop partnerships with companies working in e-health care. What more can you do in this prevention? I don't know if we can do more. I think we can work on the status quo, the current situation in we are co-founder of Future for Care, which is to develop digital healthcare where the expertise is because it affects everybody. The idea is to find startups who can help patients preventing chronic diseases and to monitor the disease. Of course, we can do more, we can invest more, but it has to be coordinated. For this roundtable, I was looking at all of the actions taken in public affairs and in the governmental area. It's absolutely amazing. The number of lists with wonderful titles, ever more pompous. I don't know what the results of all these are. Maybe it's too early to judge, but maybe, as we were saying earlier, we should go back to a more basic level and make sure that everything we do as effectively as possible, and we have the means to do it properly. And in the terms of the budgets, there isn't really an earmarked budget for prevention. We tend to, everything tends to be defined by the means, but I think it really should be controlled by the use and the needs. There is, in terms of prevention, for many years, there's a need to rebalance the financing between prevention and other areas, and we are completely under-equipped in terms of the leadership in this area. Dominique, just to point out, I'm not as I'm full of despair as that. Sometimes we get the impression that we're agonizing and we're in a terrible situation with the epidemiology and chronic diseases, with more and more people being affected by chronic diseases, including young people. We have to be aware of the importance of that, the fact that the Ministry of Healthcare is also called the Ministry of Healthcare and Prevention. That's an important symbol. We talk about the Healthcare Priority Plan, which was set up in 2018. I'm not in total despair, but we have to, as you say, use simple approaches. One of the most important things is that primary prevention is information, but information provided with taking account of psychological aspects, so that it's personalized, so we raise awareness in the most appropriate people. And then primary prevention has to be based on information, health education. It doesn't cost very much, in fact. So we have to really put the emphasis on that. But nevertheless, we're one of the European countries. We have the most smokers, the most people who drink alcohol, with 5% of the population is overweight and 17% are obese. I think we have to continue, but only personalized prevention with personalized journeys will make it possible to deal with this question of chronic diseases. Anne-Marie BAIRD, your association is a patients' association. Is that right?
Pour vous, le patient a un rôle clé, évidemment, dans la prévention.
So patients have a key role to play in prevention for you. We often say patients have to be an active participant in their own health.
Yeah, so I think it comes back to what everyone has said already there about going back to basics, about helping with the education and awareness so that people understand better their risks, what they can do. And I think the support as well needs to be there. So that psychosocial support, so that if someone is doing something that's going to increase their risk of developing a disease or a condition, that they're given the adequate supports are put in place to help them deal with that and cope with it. I think one of the things that hasn't really been spoken about yet or touched upon when we talk about prevention is around when you put these campaigns out, whether they're personalised or more broad, is around health literacy. You have to make sure that what is going out there is going to be understandable by the public, and health literacy is a big issue within all of the communities really that are dealing with different diseases. We see it particularly in lung because there is a higher incidence of lung cancer in areas of higher social economic deprivation. We need to do more when we talk about these campaigns and prevention about making a proper approach to that hard to reach population, because it's there that you can make a huge impact. So, you know, it's not just about campaigning towards the worried well, but we need to make sure that we are doing that personalisation so that we're getting that hard to reach population, particularly in those areas of high social deprivation. And I think that's where you can make a huge impact, where you talk about awareness for all sorts of different conditions and diseases.
Yes, I think is an important subject. If we carry out plans and campaigns which always involve the same citizens, we're going to leave to one side the other people. And this is what Anne-Marie was talking about. We're talking about these underprivileged areas. It's very important, because otherwise we will get these same citizens who will come in because they're already in the system. When you're carrying out prevention, you go to look for people outside the system. There are initiatives that are organized in Ireland that I know of. There are also others in France. I think we can go further. How do we bring back into the system all of the people who have been left on one side? And that's where we need our return on investment is very important. And the question of data as well. It's true that medicine has become very digitized now. When you say digitalized, we're talking about data. And data which is very precious to be able to improve this prevention. Audrey. It's very important, very precious. I think people are always a little bit afraid of using big data rather than being optimistic. We have databases. We have all of the databases we need in France. There's a framework. I'm not sure that if we add more frameworks and more laws, I think that's not really necessary. We have an overdose of laws. We have enough frameworks. We need to see how we can accelerate the use of big data. And now we have to use them properly. So, David, you said there was a problem with accessibility of this data. This is a bit of a touchy subject. We're all working in our own silo in the pharmaceutical industry. industry, disease, medical science, sickness insurance, and everybody's working hard and getting some good results. But we all know that in data, richness comes from consolidation of these different environments. So today in France, we have a problem, certainly. There are a lot of initiatives. I'm thinking of the data bank, which has begun, was there from the beginning. We began with some first use cases in April 2019. There was a use case which started with refunding from the sickness insurance company, insurance company, with our Malakoff Humanis databases. So where are we now? A little bit more than 2 years later, we have an opinion in August 2021, which was positive, but which means that we are not able to have access to this chained data. This was the authorities that gave that restriction. So we had a great initiative consisting in consolidating this data. But in the terms of use, we have not got to where we want to be yet. I think when we talk about these different frameworks, it creates a lot of inertia. This means that after 2.5 years, we haven't really done anything. We've developed other algorithms, but we have a fantastic potential. We have to save lives. We can save lives, but we're not moving forward quickly enough. So, as usual, I am making an appeal to release big data. Audrey, the same thing. So the same thing. You're making the same appeal. Yes, for you, Dominique, maybe you have easier access to this data? Not really more access, but at least we have access to the data that we generate ourselves. Good thing too. Well, provided we have all the consents, etc. In genetics, it's absolutely vital not to remain on what we call in sequencing data. We have to integrate the phenotype. The individual, the person, is all of their data. There's no genetics without the person, and the idea is to bring everything together. So it's absolutely vital to do what we call epidemiology, genetic epidemiology, because this is what gives us something enables to transform the data into medical information that is high quality and will be useful for people. But of course, it remains very difficult. So this digitalization, this e-healthcare that is progressing with the medical progress means that, of course, we are hyper-connected, which is good for prevention, but it has a few limits. Could we imagine that this prevention might become intrusive? Yes, people might think they're being followed and monitored all the time. Yes, you're right. All this has to be done with consent. So we have our data protection law, GDPR, in Europe, which helps us protect people's data. We have to be careful with this, you're right. We're also lucky because we have infrastructures that are being set up. We have for digital healthcare, so we could have health reports, and we have reports and advice that are personalized to the individuals, not necessarily patients. The idea is they'll be individuals rather than becoming patients. So, and the same thing for all of the medical professions organized in the circle of trust of this individual. They need to be able to get access to this information to carry out prevention actions and also be able to have the medical examinations they need. By having this transparency, we're able to give information that is transparent and enables us to take action afterwards in terms of behavior or medical actions. And that seems to me very important. If we look at prevention from that point of view, I think we could then switch over to have a true appropriation of personal health by people. But when you're a smartphone, you don't have the GDPR when you're on your mobile phone. Could we imagine that this prevention could be carried out despite what we want to do and without us knowing it? I don't think so. We can see that in the mechanisms that we're using, you always have to have consent. Has to have enlightened consent from the patient. This is essential. Then, of course, you have individuals who become lost, who are no longer visible to the system, and then you have the social gradient as well, because apart from the chronic disease, we have a problem of a social gradient. We have to look for those people who might be forgotten otherwise, and that's why, with the public authorities, we have to think of developing targeting systems, which are very important for these kinds of people who might be forgotten otherwise. Of course, with the patient, Audrey is in the center of the chain. Actions can be of many types. They could also be present in businesses, in companies. And it's true that in companies sometimes that there may be certain aberrations and certain problems. We've seen in the US that employees were tracked and monitored to make sure they were sitting in the right position, see whether they'd gained weight, to see if they'd lost enough weight. The risk of this obligatory prevention is perhaps to stigmatize certain population groups or maybe divide people and create a division between populations. Dominique? Well, yes, but I think the law is very protective. It's not discriminatory. There is a protection where, nevertheless, although the law protects us, we have to remain very vigilant. After that, if you don't mind, we haven't talked about one thing, which is collective prevention, which concerns a whole set of populations. The individual is important, of course. You can have a customized, personalized message, but you also a question of collective prevention. That's another P. That's the fourth P, yes, participatory. It's participation of the person itself. Here we're talking about the collective aspect. I'd like to mention, for example, the EVA law of 2007 on putting a ban on smoking in public areas that were they're closed or roofed. This caused a 15% reduction in infarctus of the myocardium. And also the barmen also had, especially amongst the barmen. Yes, we also mentioned the sectorial aspect and the individual practices of individuals. When we set up prevention programs, it works very well when they're specialized, because when you're working in a cafe or restaurant, or if you're in the metallurgy area or an architect, it's completely different. You have much less risk. I don't think we've taken account of this aspect of people's occupations in prevention, taking account, looking at specific sectors of activity in society. Another question for all of you, is prevention going to be more expensive than curative aspect? Is that possible? No, thank you for that question. Well, it's funny how you asked that question. You could have said, you looked at it the other way around, saying, what are we going to be able to gain from prevention? Here, people tend to look at prevention as a cost rather than an investment. For me, I'd prefer to say, what can we gain from prevention, rather than how much is it going to cost us? I'd like to say, if we're at the foot of the wall with prevention, it's because of the explosion in healthcare expenditure. It's an investment, and it's not very expensive. It's a question of education. I'm not talking about the technological aspects or predictive healthcare, which today only concern a small number of people, but primary prevention is essential. It's a question of education, and I mentioned the health priority plan. This is an interministerial plan, and it doesn't cost very much. But you have to have the political determination. I'd also like to point out that speed limits to 80 kilometers per hour on the roads in two directions without any central reservation is one of the elements that caused the movement of the yellow jackets. The additional idea was to reduce the number of deaths on the roads by 400, and, of course, all of the other injuries as well, of course. So it's just to say that collective prevention is not as simple as that in order to obtain the adhesion of the general population. Yes, Prevention certainly is important, but then you have the time scale is not very short. It's a long time scale. After the 15 billion from the Court of Auditors, whether it's for primary or secondary prevention, I think we have the means of using this money in a different way. So less a question of means than of leadership and efficiency and of obtaining the real impact of these means. So yes, prevention is very important. So prevention is everybody's business? Yes, absolutely, yes. Okay, we finished with 42 seconds left. Thank you very much, everybody.